Hi guys, in this video we're going to be having a discussion about the most important images pertaining to the kidneys or the renal system. The first important example of an image that I would like you to be familiar with over here is going to be of a condition that is going to be given the name of adult polycystic kidney disease. So when we are talking about the adult polycystic kidney disease, it is going to be characterized by the fact that there is going to be an individual who is usually going to be asymptomatic in the initial part of his life. But then at the age of around 40 to 50 years, he is going to be having the development of hypertension. He could be having the presence of hematuria. And this is going to be the finding that you see grossly in the kidney. So this guy is going to be having the presence of multiple cysts in his kidneys. The question that they put up to you in the exam, apart from the kidneys, the other important area in the body where we find the presence of the cystic masses is going to be the hepatic tissue. Of course, you can be having the cyst in different other organs of the body as well. For the pathogenesis of this kind of a condition, we need to be familiar with the role of an important protein which is going to be given the name of polycystin. And there are two important types of genes that we need to have an idea. One which is going to be given the name of the PKD1 gene, and the second one which is going to be given the name of the PKD2 gene. I hope from the main videos you would be able to recall the fact that the PKD1 gene is going to be having its location on chromosome 16. To be more precise, it is present on the short arm of chromosome 16, and the PKD2 gene is going to be present on the long arm of chromosome 4. We need to be familiar with the fact that patients who are going to be having the adult polycystic kidney are going to be having the presence of an autosomal dominant mode of inheritance. This condition is also going to be given in the exams with respect to its other manifestations, which can be something like the presence of an enhanced risk of Berry aneurysm. The patients are at high risk of development of colonic diverticulosis, and the individual are going to be having a development of mitral valve prolapse. Another favorite of the examiner happens to be the fact what exactly causes mortality in these patients, and that is what is supposed to be answered in the exam as the coronary artery disease. So the questions pertaining to the genetics, the appearance, the name of the protein involved, the genes, their location and the cause of death all constitute pretty important topics so far as adult polycystic kidney disease is concerned. Talking about the next one, this is going to be an example of a condition which is again going to be having the presence of multiple cysts so far as the kidney is concerned, but this condition is going to be given the name of the childhood polycystic kidney disease. Now, in complete contrast to the adult polycystic kidney disease, this condition is going to be having an autosomal recessive mode of inheritance. And the important finding that you associate with this kind of a condition is that if you're going to be looking at the cysts, they are going to be present almost at a 90-degree angle to the cortical surface. The second important fact that you need to remember is that these children are going to be having an early presentation, and they are also going to be having a development of a trouble that there is going to be development of congenital hepatic fibrosis. Now, involvement of two important vital organs of the body, the kidneys and the hepatic tissue, is going to make the survival of these babies a bit difficult. We also need to be familiar with the fact that when we are talking about the childhood polycystic kidney disease, there is going to be an important role played by a protein that is going to be given the name of fibrocystin. So recall what we discussed 2 minutes back, polycystin is going to be playing a role so far as the adult polycystic kidney disease is concerned, but fibrocystin is going to be playing a role so far as the childhood polycystic kidney disease is concerned. Now, when we are talking about the genes associated with the development of this kind of a condition, the gene that you have to remember is the PKHD1 gene. So be very careful in the exam. The gene that I had made a mention of in adult polycystic kidney disease was something like PKD1, whereas PKHD1 is the one that you associate with something like the childhood polycystic kidney disease. So that is what is to be remembered. The anatomical location of the cyst, that's one question. The mode of inheritance, involvement of the other organ, the name of the protein and the chromosomal location of the gene, which is to be remembered over here as the PKHD1 gene. This is going to be present in chromosome 6p. So that takes care of a discussion of the childhood polycystic kidney disease. Talking about the next important example of a condition, this kind of a condition is going to be given the name of, it is termed as the medullary cystic disease. The moment we are going to be talking about the medullary cystic disease, this is an example of a condition which is going to be characterized by the presence of cysts that you can make out over here. And these cysts are going to be present at the corticomedullary junction. So that's a cortex, that's a medulla, and over here you're going to be having the presence of the cystic lesions. Now, this kind of a condition acquires significance because of the fact that the clinical presentation of the patient is going to be in the form of polyuria, as well as the question may mention about the presence of salt wasting. Medullary cystic disease is going to be important because of the fact that this particular condition can progress and result in the development of renal failure. Now, we are going to be having important variants that we are associating with this kind of a disease. One which is going to be given the name of a juvenile variant, and the other one which is going to be given the name of an adult variant. Why that becomes important for you to remember is the adult variant is going to be having an autosomal dominant mode of inheritance, whereas the juvenile variant is going to be having the autosomal recessive mode of inheritance. So the importance lies in the fact that this is going to be an example of a tubular disorder, polyuria therefore, and the presence of electrolyte disturbance, as well as the presence of something like salt wasting term, along with the presence of cysts at the corticomedullary junction. That is what is to be kept in mind so far as the medullary cystic disease is concerned. Looking at the next important example of a condition which is very easy for most of the people to understand and realize, because you are having the presence of those cystic lesions, and those cystic lesions are typically going to be present in the medullary region. So this kind of a condition is logically going to be given the name of a medullary sponge disease. Medullary sponge kidney is what we are talking about as of now, because of the presence of cysts which are going to be located in the medullary region. So the sponge-like appearance because of presence of multiple cysts. What you need to remember over here in this kind of a condition is the origin of these cysts is going to be taking place in the collecting ducts. Why that condition can also be asked in your exam is for a simple fact that this kind of a condition, even though you are having the presence of cystic lesions and there is a sponge-like appearance, but still the kidney function is going to be surprisingly spared. The kidney function is going to be unaffected in these kind of individuals. So in contrast to the conditions that we talked about earlier, that means if we talking about something like the medullary cystic disease in which renal failure was a prominent manifestation, in medullary sponge kidney, the renal failure usually does not happen. So that is what is going to make this condition a bit unique. Talking about the next important topic, all-time favorite of the examiners, which is going to be the different types of casts that we are having in the urine. So first important example of a cast that we must be able to recall in the exam is what is going to be given the name of a hyaline cast. I would like you to be familiar with at least 3 or 4 points pertaining to the hyaline cast. Fact number 1, this is the only important example of a physiological cast. Point number 2, that this kind of a cast is going to be made up of a protein that is going to be given the name of the Tam horsefall protein. If anybody was to ask you about the source of this Tam horsefall protein, you should be able to answer that correctly in the exam. It is coming from the cells of the ascending limb of loop of Henle. Usually when we are talking about a protein which is going to be secreted from the tubules, logically that should be given the name of a tubular proteinuria, and we need to understand the fact that amount of the proteins which are present in the urine of this individual is typically going to be less than 150 milligrams in 24 hours. So all those points are going to be making the hyaline cast very special, because that can be present in case of a urine examination of a normal individual, accentuated by the fact that if there is going to be any kind of a condition where there is going to be a dehydration, or for that matter a reduced water intake, or for that matter a patient who is going to be having a diarrhea or a burn, then the number of casts is going to be higher. The other important finding that we associate with the hyaline cast is that sometimes in case of pathological conditions, different types of cells can appear in the urine of an individual, and those cells can actually cringe on this hyaline cast, thereby giving the appearance of the different types of the pathological cast. One of the important examples I can share with you as of now happens to be a situation in which you find that there is going to be RBCs which are going to be hanging on to the hyaline cast, and therefore this kind of a cast is now going to be given the name of a RBC cast. RBC cast, we need to understand the fact, is a prominent finding in case of an individual suffering from glomerulonephritis or nephritic syndrome. So that could be having different types of causes as we talk about in the subsequent discussion. Say for example, in case of children, one of the common reasons could be the development of post-streptococcal glomerulonephritis. In case of adults, one of the commonest reason happens to be a condition given the name of Berger's disease. The point that I am trying to highlight over here is the fact that RBC cast is going to be having a reddish appearance like this, and definitely an important prominent manifestation of nephritic syndrome. Another important type of cast that we need to be familiar with, which is going to be having a situation in which the RBCs are not going to be there, but there is going to be WBCs which are going to be attaching themselves to the hyaline cast. That is going to be given the name of a WBC cast. Now WBC cast is going to be seen as a finding of a patient who is going to be suffering from pyelonephritis. Why that becomes important is because pyelonephritis can be taken to be one of the important examples of urinary tract infection. The moment we are talking about urinary tract infection, another important example of a condition that the examiners love to go after is cystitis. But please remember the fact, cast formation takes place only and only when there is going to be involvement of the renal tubules. So in order to differentiate between pyelonephritis and cystitis, what we are using as an important parameter is the presence of WBC cast. So presence of WBC cast is a finding which is going to tell you that the UTI the patient is going to be having is going to be associated with pyelonephritis. So that is what is going to be making the presence of this particular cast pretty important. Another important type of cast which is loved by the examiners to be asked over here is the one that is going to be quite broad over here. And if you see the appearance, that is going to be having a semi-lucent or an example of a waxy appearance. So that kind of a cast is what I would like you to be familiar with in the exam. This is going to be given the name of a broad waxy cast. What makes the broad waxy cast special is the simple fact that this is likely to be seen in case of an individual who is going to be suffering from a condition, the chronic kidney disease. Examiner these days can be smart enough not to give you chronic kidney disease directly as a question, but what they can be talking about is a presence of an individual who is going to be having the presence of diabetes mellitus for a long duration of time, and subsequently after many years this individual is going to be having a reduction in his renal function. So diabetes mellitus is going to be associated with kidney problem, that is called as diabetic nephropathy, and diabetic nephropathy is the number one cause of development of CKD. So that is the alternate way which I just now shared with you, in which the examiners can be asking you a question on the broad waxy cast. So all in all, you need to remember the broad waxy cast is a finding of chronic kidney disease. Looking at the next one, we need to be familiar with an example of a cast in which we find that there is going to be fatty acid or the presence of fatty material going to get deposited on the hyaline cast, thereby giving the name as fatty cast. Now why fatty cast become important is because that is very much suggestive of the fact that the individual is going to be having the presence of lipiduria. Fact number one, this is going to be an important finding in a patient who is going to be suffering from nephrotic syndrome. Fact number two, such type of fatty cast can also be seen in case of an endocrinological disorder, which is going to be the hypothyroidism. As and when we are making a mention of the fatty cast, it is important for us to understand that the fatty casts are going to be having a refractile nature so far as their appearance is concerned, but under the polarized microscopy, they are going to be having an appearance which is given the name of oval fat body, or we can be using or reading a term in the exams which is going to be given the name of the Maltese cross. So Maltese cross in the urinary examination of an individual is going to be suggestive of something like a fatty cast. Why that Maltese cross also becomes important is because not only is a Maltese cross appearance associated with the presence or involvement of nephrotic syndrome, but that can also be seen in case of an individual who is going to be suffering from a genetic disorder which is given the name of Fabry's disease. So that was a question which was asked in one of the recent exams. This is what we need to have an idea so far as a fatty cast is concerned. Talking about the next important example of an image, we need to be familiar with an example of a condition which is going to be post-streptococcal glomerulonephritis, an example of a condition which is going to be one of the commonest disorders, the most common reason for development of nephritic syndrome or glomerulonephritis in the pediatric age group. So easy for us to understand, PSGN, pediatric age group, that's the commonest condition that is going to be associated with glomerulonephritis. So far as this condition is concerned, we just need to recall the fact that this is an example of a condition which is going to be seen in case of children with a history of development of some kind of a skin infection or sore throat. The time lag for the development of manifestations between the renal manifestations and the antecedent sore throat is going to be anywhere close to 10 to 14 days. Fact number 3, this condition is characterized by formation of antigen antibody complexes, thereby recall that this is an example of a type 3 hypersensitivity reaction. Now, when we talk about this kind of a condition, the child is going to be having a history of passage of a cola-colored urine, and the mother would tell you the fact that there was a presence of a sore throat about 10 to 14 days prior. We look at the biopsy findings in case of these individuals, you would be having a diffuse involvement of the glomerulus, which means practically all the glomeruli are going to be affected in these individuals. Secondly, the glomeruli are going to be hypercellular. So, diffuse hypercellular glomeruli, that's a term which the examiners love to write it down, and that is sometimes which is going to be pretty much visible to you as well. The complete glomerulus is actually filled up with the infiltrating neutrophils. We need to understand the fact that there is going to be the deposition of the antigen antibody complexes, and these antigen antibody complexes can be present in the subendothelial area, they can be present in the intramembranous area, they can be present in the subepithelial area. These immune complexes are going to be giving you a granular appearance so far as an immunofluorescence microscopy is concerned. And that kind of a granular appearance is what is going to be reminding you of a characteristic appearance that the examiners love to ask you time and again. This is given the name of starry sky appearance. I take that opportunity to revise with you the 4 questions which the examiners quite commonly ask you. Fact number 1. Starry sky appearance in the renal biopsy on immunofluorescence is very much suggestive of post-streptococcal glomerulonephritis. That's 1. Starry sky appearance on the lymph node biopsy is going to be associated with the tumor that is given the name of, and that would be answered as the most rapidly proliferating tumor, which is, you know that right, African child having involvement of jaw mass, pretty good, Burkitt's lymphoma. When you talk about starry sky appearance, that can be seen on the echo of an individual who is undergoing a cardiac examination suggestive of cardiac amyloidosis. When you talk about the starry sky appearance, which is going to be seen so far as a radiological investigation of the brain is being performed, something like a CT scan, you think in terms of something like neurocysticercosis. So 4 important starry sky appearances that we have talked about as of now. But to come back to our discussion over here, the starry sky appearance contributed by immune complexes giving you the presence of this kind of an appearance, and this is what is going to be the shiny dot-like appearance because of the presence of immune complexes. Examiners can sometimes test your nerve when they ask you about the electron microscopic finding out of the 3 areas where the immune complexes can get deposited. the subendothelial, the intramembranous and the subepithelial. The most characteristic location happens to be the subepithelial location. Now these immune complexes therefore are going to be having an appearance which is going to be described in the books by the name of a subepithelial hump. So child having history of passage of cola colored urine and antecedent history of a sore throat, gap of 10 to 14 days, electron microscopic examination of the kidney biopsy showing you subepithelial hump, all goes in favor of post streptococcal glomerulonephritis. Water restriction, salt restriction, administration of antibiotics all result in an excellent recovery so far as this condition is concerned. Talking about the next important example of a glomerulonephritis, that is going to be given the name of RPGN, which stands for the rapidly progressive glomerulonephritis. Now rapidly progressive glomerulonephritis is also going to be having another important term which is being used quite frequently for it, and that is crescentic glomerulonephritis. The moment you're going to be reading about the term crescentic glomerulonephritis, this is what I would like you to understand over here. There is excessive proliferation of the parietal epithelial cells, there is an infiltration caused by the monocytes and the neutrophils, and there is a deposition of a protein given the name of fibrin. All that is responsible for having a crescent-like appearance, which is going to be therefore associated with the term crescentic glomerulonephritis. The rapid proliferation of the cells over here is going to result in a reduction in the renal function, which therefore is going to be responsible for causing an enhanced risk of development of kidney failure in these patients. So watching out through the main videos, we understand the fact that kidney failure is going to contribute to mortality in these patients, and that too happens at a very fast pace, usually within a span of few weeks to months. When we are talking about RPGN, we need to remind ourselves of the fact that RPGN can be having three important subtypes. The type 1 RPGN is going to be an example of a condition in which there is going to be formation of an antibody against the glomerular basement membrane, something that you might as well find in a patient suffering from a condition like Goodpasture syndrome, right? If you talk about the type 2 RPGN, that can be seen in an individual who is going to be suffering from immune complex disease. So I've heard of conditions like SLE, henox-stonlein purpura, and different types of conditions where you are going to be having immune complex formation. When you talk about type 3 is the one you don't have anti-GBM antibodies, you don't have immune complexes, but that is going to be associated with, and therefore the term posse-immune RPGN, something that you associate with different types of vascularity disorders. Let's say, for example, vaginous granulomatosis, or I would say the new name granulomatosis with polyangiitis. So what I wanted to understand over here is that these three variants are eventually going to result in a situation wherein the patient is going to lose his renal function within a span of few weeks to months, and that is what is going to be associated with the development of a condition given the name of RPGN. So that is what we need to be familiar with the fact. We should be able to identify those crescents, because on the biopsy, the more the number of crescents, the greater is going to be the compromise of the renal function. And that is exactly what is going to translate into the patient going to be having a poor prognosis. So prognosis of an individual is directly proportional to the number of crescents which are going to be observed in the renal biopsy examination. Talking about an example of a question which has been asked in the exam time and again, you have a situation in which the individuals are going to be having the presence of hemorrhagic spots on the cortical surface of the kidney, and that is what is going to be given the name of a flea-bitten kidney. Now, as and when we are making a mention of something like a flea-bitten kidney, this is not an example of a very specific condition. That means you do not associate flea-bitten kidney with one particular disorder. It can be seen in case of a multiple range of disorders. Say, for example, an individual who is going to be suffering from malignant hypertension, can be seen in case of an individual who is going to be suffering from a condition like post-streptococcal glomerulonephritis, can be seen in case of an individual who is going to be suffering from different types of vascularity disorders, may as well be seen in an individual who is going to be suffering from infective endocarditis, can be associated with immune complex formation in leukemias and lymphomas. So all I'm trying to say over here is that you should be able to pick up the flea-bitten kidney appearance, those hemorrhagic spots that are dark spots appearing over here, and you should be able to remember at least few common causes for the development of this kind of a condition. Talking about the next important example of a condition, again a hot favorite for the examiners, we talk about what is going to be given the name of Berger's disease. Now Berger's disease, as we have talked about earlier as well, is going to be given the name of IgA nephropathy. So automatically that would remind you of the fact that you have a problem at the level of an antibody which is IgA subtype, and that is causing the kidney trouble. Patients are typically going to be adults, and that is what I have made a mention of with you time and again. Berger's disease is a problem of big people. That's a big people's disease. So post-streptococcal glomerulonephritis is an example of a pediatric disorder, whereas this is an example of big people's disease. Now, when we talk about Berger's disease, we need to remind ourselves that this condition can also be having a history of development of a sore throat or upper respiratory tract infection. However, the development of the clinical manifestation takes place quite rapidly. So within a span of like 48 to 72 hours, the individual is going to be having the development of manifestations. Patient at times could be even having the development of microscopic hematuria also. When you talk about Burgess disease, because of the presence of abnormal IgA antibody, there is going to be presence of the IgA receptor, which you are all aware, CD71, which is going to be present on the surface of, yes, think about that, you know it. Which part of the glomerulus is going to be having the receptor for the IgA antibody? Pretty right, CD71 receptor present on mesangial cells. So that would be an interesting and an important phenomena which is going to be associated with image-based question in the exam, that what you find in these patients is primarily at the level of the histological examination, there is mesangial tissue involvement. That's characteristically what you find over there. Similarly, the same thing, the immune complexes and the deposition of the IgA antibody in the mesangium can be appreciated on the immunofluorescence as well, and this is the pattern that we're going to be observing over there. So any kind of a question which talks about, either in writing they talk about the term mesangial involvement, or they talk about this kind of an image, and I wanted to identify the mesangial involvement in particular, intervening connective tissue areas which are going to be affected either in the, I would say, hematoxylin eosin staining examination, or in with respect to something like immunofluorescence examination, that is very much suggestive of something like Burgess disease. Now, the history and the age group as well as the presence of the involvement of the affected area is all going to be extremely critical so far as differentiating this condition from the post-streptococcal glomerulonephritis is concerned. Talking about the next important example of a condition, this condition has been asked exceptionally and importantly in the INICET kind of an exam, Alport syndrome. Alport syndrome is important because this is an example of a condition which can be transmitted from one generation to the other by all mechanisms known, that's autosomal dominant, autosomal recessive, X-linked dominant, X-linked recessive. However, the commonest mechanism or the mode of inheritance which is going to be seen from one generation to the other is going to be X-linked dominant. The condition is going to be characterized by the fact that there is going to be a defect at the level of collagen type 4, and particularly what is going to be seen in these individuals is that there is going to be an involvement of a particular chain. Most commonly, patients are going to be having the involvement of the alpha 5 chain. Please understand the fact, when we are talking about a condition given the name of familial hematuria or benign familial hematuria, you get the involvement of the alpha 4 chain over there, and in case of something like the Good-Passer syndrome, you get the role of the alpha 3 chain. I'm talking about over here alpha 5 chain of collagen subtype 4, which is going to be defective in these patients. What is interesting for us to note in context of Alport syndrome over here is that there is going to be a variation, there is a variation so far as the thickness of the collagen is concerned. So at some places it is going to be thick, and at other places the thickness of the basal membrane is going to be very less. Now this kind of a variation in the thickness of the basal membrane is going to be associated with a finding, and this kind of a finding has been asked by the examiners. It is going to be given the name of a basket weave appearance. This basket weave appearance is what you need to remember is appreciated typically on the electron microscopic examination of the renal tissue. So for Alport, you need to remember about the mode of inheritance. You need to remember about the variation in the thickness of the basement membrane, the type of collagen which is going to be involved, collagen 4, and if possible the chain as well. And you need to be familiar with this particular term, the basket weave appearance, which is going to be associated with the development of this condition. Now, a lot of times people do have a trouble in identifying the different types of immunofluorescence patterns, and therefore I thought it would be actually good if I can at least help you differentiate between the two commonest patterns which are given in your exam. The first pattern that they give you in the exam is what is going to be given the name of linear immunofluorescence. Now you see, linear immunofluorescence will typically be seen, say for example, this happens to be the basal membrane and you have antibodies which get attached over here. So antibodies are going to be having a uniform attachment with the affected area, and therefore what you're going to be seeing over here is that every part, I mean if you see closely over here, every part that is going to be having a shiny appearance. It's almost like a road which is going to be well lit, and therefore this is given the name of a linear immunofluorescence. On the other hand, let us say we are talking about the second pattern of immunofluorescence, which is going to be given the name of the granular immunofluorescence. Granular immunofluorescence implies that there would be appearance which is going to be like a granule, irregularity. So suppose this is the basal membrane and you have different types of immune complexes, right? 1, 2, 3, 4. Those 4 areas where the immune complexes are present are going to be appearing very characteristically to you as you find in the image over here. Can you see it over here? So one way of looking at the immunofluorescence picture is that there is going to be a uniform lightening up of the tissue. That is the linear immunofluorescence. And if you're going to be having a patchy, a scattered, I would say, because of immune complex deposition kind of a shiny appearance, that is what is going to be given the name of granular immunofluorescence. So any kind of a question in exam, which is characterized by antibody formation against the glomerular basement membrane. Say for example, Goodpaster syndrome, that is going to be having a linear immunofluorescence. On the other hand, if I have an immune complex disease which is going to be getting a granular appearance, say for example a condition like membranous glomerulopathy, I would be getting a picture like this. So in order to differentiate the two different types of questions, just have a close look at the kind of immunofluorescence picture which the examiner is giving to you. Read out the history, because a lot of times, in fact 80% of the time, with the current pattern of examination, you get a good hint with respect to what can be the possible condition. So those images are going to be kind of accessory in nature to you. They can just help you confirm the diagnosis as well. So that is what you need to remember so far as the two different patterns are concerned. Now once we are through with the different causes of nephritic syndrome, we need to be familiar with an example of a condition in which typically we are going to be talking about massive proteinuria, presence of hypoalbuminemia, presence of hyperlipidemia, lipiduria, and you're going to be having the development of edema. So those four manifestations that I just made a mention of are typically seen in a patient suffering from nephrotic syndrome. One of the very common causes of nephrotic syndrome, especially in case of children, happens to be a disease which is given the name of, you know that right, that's minimal change disease. The child walking in your pediatric OPD itself is the first giveaway, and this child is going to be having the presence of a facial puffiness, there is a facial edema. Of course, most of us understand that the development of this kind of edema is going to be contributed because of the presence of excessive sodium and water. If for some reason that is not given as an option in the exam, you can always take as hypoalbuminemia contributing to this kind of a swollen appearance. But what I wish to tell you over here is that the child is going to be having a presence of a facial edema, and there is going to be reduced urine output. There is going to be presence of frothiness in the urine. That all can be seen with respect to something like minimal change disease. Now, apart from the gross appearance, what can be seen in these individuals can be, sometimes examiners will try to be putting up on your nerves and they can be giving you some kind of a serum electrophoresis pattern. So normally we talk about different types of patterns, and I explained them in the different subcategories of disorders. Say for example, multiple myeloma, say for example, nephrotic syndrome, liver disease. But what I would like you to understand over here is that this is the normal pattern that you are going to be getting, right? So predominant protein that most of us understand happens to be albumin. However, in case of an individual who is going to be having an albumin loss in the urine, you obviously find that this particular peak is going to be reduced. So one of the characteristic findings, and then you find that there is going to be an increase in the alpha 2 globulins at times because of infections. Even the gamma globulin peak can be a bit higher. That is what you need to remember so far as the serum electrophoresis pattern is concerned. Now looking at the kind of a picture that you would expect to see by which you make a confirmatory diagnosis for minimal change disease, you need to understand the fact first, the normal finding. Normally on the electron microscopic examination, you would be having the presence of the foot process of the podocytes. So these foot process or the podocytes are very important for repelling the proteins. However, in case of an individual suffering from minimal change disease, there is a diffuse effacement, and that's a term that they love to give you in the exams time and again. Diffuse effacement of the podocytes, as a result of which the repelling power of the podocytes is lost, and that is what is going to contribute to the development of massive proteinuria. So you don't have any podocytes which were clearly visible on the left side, and that is what is going to be contributing to the development of this kind of a condition. Now the moment we are going to be talking about minimal change disease, let us also remind ourselves of the fact that these patients are going to be having what is going to be given the name of selective proteinuria. And this selective proteinuria has got a significance that if you administer immunosuppressive therapy in the form of steroids, then the child is going to be having an excellent response. So steroid therapy is going to be almost like a lifeline for this particular child, at least for majority of the children. Then this is what is going to be seen typically in association with minimal change disease. Looking at the next important example of an image, this is going to be an example of a condition in which you find that there is characteristically, I hope you can make out those black deposits, the electron dense deposits over there, and this is going to be an example of a condition which is characterized by the subepithelial immune complex deposition. The same thing which can be appreciated on the electron microscopy can also be confirmed by looking at the immunofluorescence picture over there, in which you have this kind of a speckled pattern. You see those dot-like appearance, the irregularity and the thickness, which is going to be very much suggestive of the fact that there is going to be the presence of immune complex deposition. So this is an example of a condition that is going to be given the name of membranous glomerulopathy. Membranous glomerulopathy, incidentally, is what you need to remember for exams, for the fact that this is an example of a condition which commonly contributes to development of nephrotic syndrome, most commonly in the elderly, particularly very commonly associated with a patient having a history of suffering from some kind of a solid cancer. Is likely to be seen in an individual who is going to be having a history that she is suffering from a condition like a connective tissue disorder like SLE, or can at times be associated with different types of infections. The important point about this kind of a condition is what I would like to highlight over here, the presence of the subepithelial immune complexes over here, and that is what is going to be giving an irregular appearance. I hope most of you can remember the fact that this is going to be associated with the term the spike and dome appearance. Spike and dome appearance. Similarly, the condition is going to be having this kind of an irregularity, the granularity that you find over here on the immunofluorescence examination, which can very well be differentiated from the smooth appearance, the linear appearance that you are going to be getting in case of a condition like anti-GBM antibody conditions like Goodpaster syndrome. So, important for you to understand the fact that these are the important associations with membranous glomerulopathy. Not to forget the fact, membranous glomerulopathy is an important cause of development of non-selective proteinuria, and therefore, apart from steroids, the condition usually requires administration of other stronger immunosuppressive therapies like cyclosporine as well, sometimes to manage the proteinuria of the patient. So that is what we need to be familiar with so far as the pathogenesis or the histological appearance over here is concerned. Of course, we can just talk about the fact that in this condition, there is most of the patients having the presence of an idiopathic membranous glomerulopathy, in which the patients are going to be having formation of antibodies, which is going to be against the phospholipase A2 receptor. Please be familiar with the fact the animal model that we have for membranous glomerulopathy is what is going to be given the name of Hayman's nephritic model, and the corresponding antigen that you're going to be having in the rat happens to be what is given the name of Miguelin. So all those have been previous exam questions which should be well taken care of by you as and when the examiner is going to be putting up that in any exam. What you also need to remember over here is that apart from the commonest cause of nephrotic syndrome in case of children as well as in case of elderly, we can just quickly revise the fact that the commonest reason for development of nephrotic syndrome in case of adults happens to be these days the focal segmental glomerulosclerosis. That is also an example of a condition which is going to be associated with the development of nephrotic syndrome in a patient suffering from HIV. Pretty commonly seen in an individual who is going to be having a single kidney, as well as in case of individuals who are going to be having the development of a disorder like sickle cell anemia. We need to be familiar with the fact as and when we are making a mention of something like FSGS, it's important for us to keep in mind that especially in an individual having a history of suffering from HIV, there is going to be a rapid deterioration of the renal function or the glomerular function, which is going to be associated with the term collapsing glomerulopathy. You need to be familiar with the fact that HIV associated nephropathy, as we talked about in the main video section, can be having one component in the form of collapsing glomerulopathy. Also, there are different variants of FSGS that we need to have an idea, especially the examiners can be asking you question talking about the one which is going to be having the worst prognosis, that is going to be something like the glomerular tip variant, and the one which is going to be having the collapsing variant, which is going to be having the worst prognosis because of its association with HIV, and the one which is going to be having the best prognosis, that is going to be the glomerular tip variant. So that is what we need to be familiar with so far as FSGS is concerned. The next important example of a nephrotic syndrome condition is what we need to keep in mind, which is going to be given the name of MPGN. MPGN thereby standing for the membranoproliferative glomerulonephritis. The condition is also going to be given the other important name of mesangiocapillary glomerulonephritis. Now there are different variants, but the first variant is going to be having the presence of, as you can appreciate over here, there is going to be presence of a thickening of the basement membrane. This is going to be having the presence of subendothelial immune complexes which are going to be present over here, and on these immune complexes you are going to be having the material which is going to be covering them. So you are going to be having the presence of what is going to be given the name of a tram track appearance. The tram track appearance is what is going to be possibly appreciated much well over here in this kind of an image where you have the presence of this kind of a double ring that you get over here. This is going to be associated with the term the tram track appearance. So we need to be familiar with the fact that the MPGN type 1 is going to be having the presence of subendothelial immune complex deposits, and you're going to be having the presence of what is going to be given the name of tram track appearance, which is going to be a characteristic feature associated with MPGN type 1. Talking about the MPGN type 2, we need to be familiar with the fact that in this kind of a condition, you do have the role that is going to be played by an important antibody which is going to be given the name of the C3 nephritic factor. Of course, I would request you to go back and have a look at this particular discussion that I've had with you in the main videos. I would also like you to be familiar with the fact that this condition is also going to be having a deposition of the immune complexes, and there is going to be a deposition of unknown material, a black color deposit, because of which it is going to be associated with the term dense deposit disease. So when we are talking about MPGN type 2, you need to be familiar with the fact C3 nephritic factor autoantibody, and then it is also going to be having the presence of what is being given the name of the dense deposit disease. Of course, this is an example of a condition that can be having multiple risk factors and it can be associated with other autoimmune disorders as well. So you need to be familiar with the different types of infectious organisms and the different types of nephrotic syndrome that they predispose to in an individual that we have talked about in the main video section carefully. Talking about the next important example of a condition that is going to be given the name of diabetic nephropathy, which is going to contribute to the leading cause of development of chronic kidney disease. Now, when we talk about diabetic nephropathy, a lot of questions which are going to be asked in the exam. So, in the initial phase of the condition, the patients are going to be having the presence of a hyperfiltration injury. This is going to be characterized by the development of the thickening of the basal membrane. Subsequently, you are going to be having the deposition of the mesangial matrix and the extracellular collagenous material in the form of development of those nodule-like structures. So, that is what is going to be given the name of nodular glomerulosclerosis. The nodular glomerulosclerosis is also going to be given the other important name of Kimmelstein-Wilson lesion. We need to be familiar with the fact that if it is unchecked, then the nodular glomerulosclerosis can progress into something which is going to be given the name of a diffuse glomerulosclerosis, and that is what is going to be the just preceding event before the development of the chronic kidney disease. So the characteristic lesion that you have in case of diabetic nephropathy happens to be what has been asked in your exam time and again, the nodular glomerulosclerosis or the Kimmelstein-Wilson lesion. We need to be familiar with the fact that there can be certain other changes that we have made a mention of in the video section that you have read in the discussion of this particular topic, wherein we talk about the presence of glycogen in the proximal tubular cells. So that is what is going to be given the name of Armani-Epstein change, a question that has been asked in the exam relatively recently. And we can be talking about an example of situation in which the patients could be having clinical manifestations ranging initially from something like a microalbuminuria, where the protein loss in the urine of an individual is going to range between 30 to 300 milligrams per 24 hours, which then goes into something like a subnephrotic proteinuria, eventually nephrotic proteinuria, and in the end, the patient is going to end up in something like CKD, thereby ending in the end stage renal disease. So all in all, what I wanted to be at least aware of here the fact that patients are going to be having the presence of those kind of nodules which are going to be example of ovoid masses, past positive ovoid masses, and that is very much going to be suggestive of something like a diabetic nephropathy. Talking then about an example of a condition which used to be loved in your second year med schools, the condition is going to be given the name of chronic glomerulonephritis. Now this is an example of a condition after many years of suffering from some kind of a glomerular injury, the patients are going to be having a reduction in the renal function. The condition is going to be characterized by the fact that there is going to be a bilateral involvement, and typically this is going to be associated with a bilateral symmetrical involvement in which you were shown specimens in which there is going to be a bilateral contracted kidney. Now the way by which we are going to be making a diagnosis of this kind of a condition is this is going to be the glomerular area, and surrounding the glomerulus you are going to be having the deposition of collagen. Now, when we talk about the fibrous tissue deposition, the collagen deposition out of the glomerulus, that would be given the name of a periglomerular fibrosis. And the way by which you're going to be confirming the presence of collagen over here is the special stain that I wish you to be familiar with over here, which has been asked in your exam relatively recently as well. This is going to be given the name of the Messon's trichrome stain. Messon's trichrome stain. Please be familiar with the fact that the Messon's trichrome stain is not to be confused with the Meson-Fontana stain that we talked about in a discussion of cell injury. Messon's trichrome stain is what is going to be giving the collagen a blue color, and we need to be familiar with the fact that the Meson-Fontana is the stain that we are using for the identification of a pigment like melanin. So, the presence of periglomerular fibrosis and the blue color deposition showing you that gradually fibrous and collagenous deposition is going to cause compression of the glomeruli, thereby causing a development of reduced renal function and thereby causing a bilateral contracted kidney. That's what we need to be familiar with so far as the chronic glomerulonephritis is concerned. Talking about the next important example of a condition which is going to be pyelonephritis, typically an example of an ascending tract infection caused by different types of organisms, most common of which happens to be Escherichia coli. Of course, we can be having a situation in which an individual can be having the presence of acute pyelonephritis, which can be coming from the hematogenous route, maybe caused because of something like a tubercular infection. When we are talking about the chronic pyelonephritis, again an example of a condition in which the patients are going to be having the presence of a contracted kidney. Now, the moment we are going to be talking about the chronic pyelonephritis and a small shrunken kidney, it's important for us to understand that in comparison to chronic glomerulonephritis, in which you are having the presence of a bilateral symmetrical involvement. Mark my words over there for the exam, chronic glomerulonephritis, bilateral symmetrical involvement. In case of chronic pyelonephritis, you get an asymmetrical involvement. That is what is very important. Similarly, when we are talking about a chronic pyelonephritis, you're going to be having a peculiar shape of the scar, what is being described in the books by the name of a U/V scar, and that is going to be typically causing involvement of the upper or the lower poles. The moment we are looking at the histological picture of chronic pyelonephritis, it is characterized by the fact that there is an influx of cells like the lymphocytes and the macrophages. So you have lot of those black dots which are suggestive of chronic inflammation. Essentially, there is going to be involvement of the tubules and the interstitium area. Thereby, what we understand over here is that there is going to be the presence of, can you see and appreciate over there? In fact, it is mentioned on the slide as well that there is an atrophy of the tubules because of the damage. There is going to be an atrophy subsequently because of the vascular compromise, and then there is a presence of the pink colloidal material over there, which will actually give you an appearance, or it may actually confuse you with the appearance of a slide of thyroid that you see histologically. For this reason only, the colloid pink deposition in the tubular lumen is going to be reminding you of a thyroid, and for this reason only, you need to understand the fact that we are using a term in association with chronic pyelonephritis, which is given the name of thyroidization of the renal tubule. So for a one-liner question, or for that matter an image, thyroidization of the renal tubule is a finding of, you need to answer that as chronic pyelonephritis. Please be familiar with the fact, examiners are going to be most of the times kind enough to give you one picture of a glomerulus here and there, so that you do not confuse it with the histological slide of a thyroid. So that's a pertinent question that a lot of people have asked me in the doubt section as well. But then this is what I would like you to be familiar with. Look out for that glomerulus, and then the thyroidization of the tubules is what is going to be extremely helpful. Of course, you are not going to be having the typical thyroid follicles over here. So that is another way by which you are going to be distinguishing this condition from the histological appearance of a thyroid. So coming back to our discussion, chronic pyelonephritis, you have asymmetrical contracted kidney. You have got the presence of inflammatory cells. There is going to be a tubulointerstitial inflammation, as we say, and there is atrophy of the tubules with the accumulation of a colloid-like material. So thyroidization of the tubules in the kidney is a finding that you associate with chronic pyelonephritis. Talking about the next important example of a condition that is going to be given the name of renal papillary necrosis, which I am going to be helping you understand with the help of those arrows. An example of a condition which can be having n number of causes, but important causes that I would like you to be familiar with over here is the number one cause over here happens to be an increased risk for development infection in a patient suffering from diabetes mellitus. That's usually the number one cause. Condition number two, which can predispose to the development of renal papillary necrosis, can be an individual who is in the habit of consumption of painkillers or the NSAID, so analgesic nephropathy. You can also have it in case of individuals who are going to be suffering from a hematological disorder like sickle cell anemia, and you can also see that in case of an individual who is going to be having some kind of an obstructive uropathy. But by far in your exam, if we are talking about fact number one, the commonest reason for development of renal papillary necrosis, that is what is to be answered in the exam as diabetes mellitus. Talking about the vascular disorders that we can quickly have a look at over here in the histological slide, what you get over here is that there is involvement of the blood vessels over here, and these blood vessels are going to be showing you the presence of a pinkish hyaline deposition of the material. So that pink hyaline deposition of the material in the blood vessel is very much suggestive of a change that we have made a mention of in detail in our section of the main videos, that is given the name of hyaline arteriolosclerosis. I told you over there as well that the vascular changes in the small vessels are most prominently seen in the renal tissue, and because of the vascular compromise over here, I mean the lumen is going to get narrowed, and therefore the gross appearance of the kidney that you get over here is the presence of a leather-like appearance of the cortical surface. So leather grain kidney. Leather grain kidney is what is going to be associated with an individual who is going to be suffering from a condition which we are talking about as of now, which is given the name of benign nephrosclerosis. That's a condition that you just need to be having an idea about. Benign nephrosclerosis. And the reason for the development of benign nephrosclerosis happens to be the fact that these individuals are going to be having the development of a hyaline arteriolosclerosis. Please be familiar with the fact that such leather grain appearance of the kidney can be seen in case of elderly individuals. They can be seen in case of individuals having hypertension. They can be seen in case of individuals suffering from diabetes mellitus. So all those conditions that I have discussed with you separately in the CVS section as well, wherein the different causes of hyaline arteriolosclerosis is what I made a mention of. Now this is to be contrasted with the second appearance in the blood vessels, in which this is the glomerulus that you can make out, in which you are going to be having the presence of concentric rings of smooth muscle proliferation. And that kind of a change is what is going to be given the name of hyperplastic arteriolosclerosis. hyperplastic arteriolosclerosis. Now, when we make a mention of hyperplastic arteriolosclerosis, that is going to be associated with a condition like malignant hypertension. So, watch out for that fact in the exam. Malignant hypertension causing this kind of a condition, and therefore the change in the kidney is going to be given the name of malignant nephrosclerosis. So, all other following are causes of benign nephrosclerosis, except, and one exception that you must remember over here is the high intensity of the blood pressure, which is seen in case of an individual suffering from malignant hypertension. That gives me an opportunity to show you the appearance of the cortical surface of the kidney. Because of the sudden increase in the blood pressure, the small blood vessels are going to rupture, and that is what is going to be responsible for causing, I hope you can appreciate that much clearly over here, hemorrhagic spots on the surface of the kidney. So again, that is going to be giving an appearance, what we talked about earlier, the flea bitten kidney. So leather grain kidney is going to be seen as a finding of benign nephrosclerosis, whereas flea bitten kidney is going to be the appearance that you see in a patient suffering from malignant nephrosclerosis and contributed by the presence of a condition like the hyperplastic arteriolosclerosis. Talking about the example of a condition in which a slide is going to be given to you, and when the history in the exam is going to be talking about a child who is going to be having the presence of an abdominal mass, and the child is going to be having a passage of altered color of urine because he is having hematuria, and the child is not well because he is having fever as well. So all that would be giving a good enough hint that the examiner wishes to talk about an example of a tumor that is going to be given the name of Wilms tumor. Now, Wilms tumor is going to be characterized with the fact that one of the precursor lesions that we have in case of Wilms tumor happens to be the presence of nephrogenic rests. When you talk about Wilms tumor, of course, you are going to be having the association between WT1 and WT2 gene, the example of the genes which are going to be present on chromosome 11p. We need to be having an association with Wilms tumor with different types of syndromes, the commonest being the Wager syndrome, the WAGR syndrome. We then talk about its association with the Dennis-Brass syndrome, and we definitely make a mention of Wilms tumor with the Beckwith-Weidman syndrome. Wilms tumor is characterized by the fact that it's an example of a tumor which is going to be triphasic in nature. Triphasic in nature. So it is going to be having the presence of blast-like cells. You see those cells which are going to be having a hyperchromatic nucleus and going to be reminding you of dark nuclear containing cells. We do have the presence of the epithelial component, which you can appreciate over here with the help of the poorly formed tubule-like structures, and then you have the presence of the intervening stroma. So triphasic tumor, which is going to be associated with a blastemal component, an epithelial component, and a stromal component. That's a characteristic finding that you associate with the Wilms tumor. Also be familiar with the fact that as and when we are making a mention of Wilms tumor, at times the patients are going to be having the presence of P53 gene mutation. The P53 gene mutation is going to be associated with the tumor becoming more aggressive, because that would histologically be associated with development of more anaplasia, and if there is going to be more anaplasia, the prognosis of the patient is going to get poor. In general, otherwise, Wilms tumor is going to be detected between the age group of 2 to 5 years and is typically going to be having somewhat good prognosis, except for the fact if there is anaplasia, that is a very important adverse prognostic factor. That is what we need to remember so far as Wilms tumor is concerned. Talking about an example of a tumor that the examiners love to talk about time and again with respect to something like the renal cell carcinoma, also given the name of a hypernephroma, also given the name of a Graves tumor, also given the name of an intensivus tumor or an interns tumor. We need to be familiar with the fact that renal cell carcinoma is given the name of the great masquerader of the human malignancy. So this condition can mimic practically anything and everything, but then we just need to be familiar with the fact that this tumor is going to be having an involvement, it causes involvement of the different lobes. So it's an example of a tumor which is going to be either affecting the upper pole or the lower pole. Of course, one of the primary risk factors for development of this kind of a tumor happens to be tobacco use, maybe in the form of smoking, maybe in the form of oral consumption. It is going to be having a higher association with exposure to something like asbestos, petroleum products, obesity. You do have the role of genetic factors. The most important ones asked by your examiners happens to be something like the VHL gene deletion. They also give you a question in the exam which was asked recently, the Birt-Hogg-Dewey syndrome in the INISET exam, and they at times talk about the fact that this condition is going to be more commonly seen in people who are going to be having a hematological condition like the sickle cell trait, especially the medullary variant. So we need to be familiar with the fact that all in all, an example of a condition which is going to be characterized by elderly individual having a presentation in the form of development of a painless hematuria. This guy is going to be having the presence of a costovertebral mass or a costovertebral pain. There is a flank pain as well. Costovertebral mass is what I would prefer over here. And then There could be a situation in which the examiner can talk about an elderly individual who is going to be having the presence of a left-sided varicocele. So even that is going to be a presentation so far as the renal cell carcinoma is concerned. Now, when we talk about the renal cell carcinoma, the CT scan is going to be the best investigation because that helps you to talk about the extent of the disease. Having said that, we understand at a microscopic level, the commonest subtype of renal cell carcinoma is an adenocarcinoma, which has got multiple subtypes. So the first variant that we talk about over here is what is going to be given the name of a clear cell renal cell carcinoma. The clear cell renal cell carcinoma. Now, when we are making a mention of the clear cell variant, we need to understand the fact that why exactly is it going to be clear? Because of presence of glycogen as well as lipids. So that was one exam question. Fact number 2 that we need to be familiar with over here is the fact that this is going to be the commonest type of renal cell carcinoma, which is going to be associated with the VHL gene mutation. So there is going to be a role that is going to be played by the 3p deletion. That is what is to be kept in mind. And of course, we need to be familiar with the fact that this is going to be the commonest variant. So clear reason is clear. I hope that is clear enough. And there is going to be VHL gene mutation, there is going to be 3p deletion, and you need to be familiar with the fact that this one is going to be the commonest variant that is observed. Of course, we need to be familiar with the other important fact that is going to be the one in which you are going to be having such papillae formation, those papillae like structures which are going to be formed over here. So this is going to be given the name of the papillary variant. Let me just write it down for you. The papillary variant of the renal cell carcinoma, the papillary variant, alternatively also given the name of the chromophilic variant. Why do we need to talk about that is because this particular variant is the one in which you're going to be having the presence of a papillary structure. Remember the fact, whenever we have any tumor in which there is formation of papillae, it may so happen that around the central fibrovascular core, you could be having the concentric calcium deposition. So one of the important histological findings, which is not appreciated over here, but then could be given in the exam, can be something like the presence of a semoma body. The papillary variant is what is going to be having a unique finding, that this is going to be having the involvement of something which is asked in the exam, that is going to be trisomy 7. There is going to be a situation in which this can be associated with something like the loss of chromosome Y, especially in the sporadic variant. So trisomy 7 can be seen both in the familial variant as well as in the sporadic variant, but loss of Y is what is going to be seen in the sporadic variants. All those have been genetic based questions which have been asked in the exam. Whenever we are going to be talking about the papillary subtype, why that becomes also important for us to understand is because of the fact that this is the commonest subtype of renal cell carcinoma in a patient who is undergoing dialysis for a long duration of time. So one of the recent risk factors that we have made a mention of is the dialysis associated variant of renal cell carcinoma, and that is what is to be answered in the exam as the papillary variant. We also need to be familiar with the third variant, which is going to be apparently having the best prognosis, and this one is going to be given the name of the chromophobe variant. So the moment we are going to be talking about the chromophobe variant, this one is going to be having the best prognosis. It is going to be like really good for the patient. But then this individual is going to be having a situation that the chromophobe variant is important. For fact number 1, it is going to be having a very good prognosis. At the same time, you need to remember, this is the variant that is going to be seen in an individual who is going to be suffering from a condition which is given the name of the Birt-Hogg-Dube syndrome. So that was a recent exam question that they talked about the Birt-Hogg-Dube syndrome, and they asked its association in which particular type of RCC would you find in such patients. You need to remember that as the chromophobe variant. Now, chromophobe variant is likely to be confusing at times with a tumor which is going to be having the presence of prominent mitochondria, which is going to be given the name of oncocytoma. And we use two important methods by which we distinguish between the chromophobe variant of RCC vis-a-vis oncocytoma. Fact number 1, what I have described to you in the video section as well, there is going to be what is going to be given the name of the Hales colloidal iron. Hales colloidal iron blue stain, and this is going to be having a diffuse staining, as you can see, with respect to something like the chromophobe variant of renal cell carcinoma. So you have a diffuse staining, the diffuse blue color, whereas in case of oncocytoma, the color is present only at the apical region. So just remember, if there is a diffuse staining, that is what is very much suggestive of the presence of a chromophobe variant of the renal cell carcinoma. The second thing by which we can make a diagnosis of the chromophobe variant can be that apart from the Hales colloidal iron blue solution, you need to be familiar with the fact that this is going to be CK7 positive. The chromophobe variant is going to be CK7 positive. I take that opportunity to revise with you a fact that whenever we are going to be talking about the subtype of renal cell carcinoma which is going to be having the poorest prognosis, that is what is to be remembered as the sarcomatoid variant. So different predisposing factors, don't forget the commonest one, tobacco use, and special conditions like dialysis, VHL gene mutation, the presence of trisomy 7, and we talk about something like the presence of Birt-Hogg-Dube syndrome, all those conditions are going to be responsible for enhancing the risk of different subtypes of RCC. Not to forget the sickle cell trait, increasing the risk of development of the medullary variant of the renal cell carcinoma. Talking about the next important topic which is going to be asked in the exam, that is in context of the nephrolithiasis, or that is in context of the renal stones. Now we have got different types of stones which are going to be present or which may develop in the kidney of an individual. The commonest example of a stone is the one which is appearing on your screen, that is going to be given the name of the calcium oxalate stone. Now you can be having the presence of a monooxalate, or you can be having the presence of a dioxalate stone, but what I want you to understand over here is that the stones which are going to be having calcium oxalate are going to be having this kind of an appearance, which is given the name of envelope like appearance. At times you can also be having the presence of a stone, calcium oxalate stone, which is going to be having a dumbbell appearance. We need to be familiar with the fact that a calcium oxalate stone is going to be contributed because of the fact that these individuals are going to be having the presence of idiopathic hypercalciuria. Additionally, we need to be familiar with the fact that this kind of a stone contains calcium, so this can be picked up on the X-ray KUB. The second important type of stone that we need to have an idea is the one which is going to be having this kind of an appearance, and the stone therefore is going to be having the presence of what is going to be given the name of a coffin lid appearance. Coffin lid appearance. The moment we are going to be talking about something which is going to be a coffin lid appearance, the stone that should come to your mind is the stone which is going to be a slow growing stone. It's an example of a stone that is going to be given the name of a term staghorn calculus, and of course that would bring a smile in your face because most of you are intelligent students who are able to remember staghorn calculus. The presence of a coffin lid appearance is what you find in a patient who is going to be suffering from, yes, the triple stone. Now, so far as a triple stone is concerned, again an example of a radiopaque stone for the fact that you can be having the presence of the calcium, magnesium, ammonium phosphate. So, calcium or magnesium plus ammonium plus phosphate, three components that would give it the name as triple stone. And this kind of a stone has a peculiarity. It is typically going to be produced in the alkaline urine. That urine can be alkaline because of the fact that individual is having an infection caused by the organism Proteus, which most of you are aware is going to be having urease, splitting thereby the urea into ammonia, causing alkalization of the urine and enhancing the risk of development of this kind of a stone. This stone is going to cause considerable damage. I hope you remember that the image I showed you, considerable damage before it is picked up clinically, else it is going to be an example of an incidental finding in case of an individual. A third important variant that we need to understand over here is what is going to be given the name of the uric acid stone. So the uric acid stone is the one which is going to be having a peculiarity that it is going to be having a history of an individual who is going to be on either suffering from gout, or you could be having a situation in which the individual has been administered any different types of the anti-cancer drugs. So those drugs are going to cause the killing of the tumor cells, thereby increasing the excretion of uric acid, and therefore it is going to be having a peculiar finding that you get irregular appearance or the irregular shape of the uric acid stones. Why that kind of a stone becomes important is because this is an example of a stone which is going to be radiolucent. Only about 5% of the kidney stones are going to be radiolucent, and definitely you need to remember uric acid stone is one of them. I take that opportunity to revise with you what are the other examples of kidney stones which are going to be radiolucent. Yes, any kind of a drug that you can remember, potassium sparing diuretic, triamterene, any kind of an antiviral drug which comes to your mind, indinavir. And then we talk about something which is given the name of a xanthine stone. So when we talk about the radiolucent stones, not only uric acid stones, but for a question which was asked in the exam, even indinavir causing stones, even triamterene causing a stone, even xanthine causing a stone, all those are also examples of the radiolucent stones. Talking about the fourth variant of the kidney stones, that is going to be having the presence of a hexagonal shape, that sometimes being referred by the name of a benzene-like structure. So this is the one that is going to be given the name of a cystine stone. Cystine stones out of the four stones that we talked about are going to be the least common, but then the shape is peculiar enough for you to be asked the kind of a question, and also we need to be familiar with the fact that this is an example of a stone being produced more commonly in the acidic urine, also an example of a stone which can be picked up on the X-ray KUB. So the shape is very important, and definitely not to forget that it is going to be the least common type of kidney stone. Of course, if you were to talk about the clinical presentation of a patient having kidney stone, the patients are going to be having the presence of a painful hematuria. Just to remind you of the fact, when you talk about the management of these patients, that would be totally dependent upon the size of stone, which is going to be well taken care of in the surgery videos. That's all about nephrolithiasis that we need to have an idea. Talking about the next important example of a condition which is asked by the examiners, this condition is given the name of malakoplakia. Now, when we talk about malakoplakia, we just need to be familiar with the fact that this is going to be an example of a chronic bacterial inflammatory condition. So, it is an example of a chronic cystitis. The organisms which can be associated with malakoplakia can either be Escherichia coli, or you could be having an infection caused by the Proteus over here. The point that I am trying to highlight over here is that there is a bacterial infection, so there would be the presence of macrophages, and these macrophages are going to be having a foamy appearance because they try to ingest the bacteria. The point that I am trying to make over here is that these foamy macrophages are going to be given a special name. They are going to be given the name of the von Henzemann cells. So in the exam, they may be asking a question talking about the von Henzemann cells, which are going to be seen as the other name given to the foamy macrophages that you would have in a patient suffering from malakoplakia. Now, because of the incomplete bacterial digestion, the point is that there can be basophilic inclusions which are going to be consisting of either iron, which can be appreciated in case of an individual suffering from malakoplakia, and these kind of inclusions that you appreciate over here. They could be having the presence of iron, they could be having the presence of calcium. This is what is going to be given the name of Michaelis-Guttman body. So examiners in the past used to ask you questions which were talking about Michaelis-Guttman body as a feature of, and the straight away answer was malakoplakia. I mean, Michaelis-Guttman, M for Michaelis, M for malakoplakia, that helps you. But as a concept now that you're going to be given in the exam is an individual having a chronic cystitis, he is going to be having the presence of a superficial ulcer, he is going to be having the presence of incomplete bacterial digestion, and that causes deposition of iron and calcium, which can be given the name of Michaelis-Guttman body. So one appearance can be something like this. Another appearance which can be made out over here is the presence of iron deposition over here and the presence of calcium deposition, going to be giving you a basophilic appearance, which can be picked up with the help of special stains as well. So you can be using something like maybe a PAS stain, I would say, or you can be using any other stain. PAS stain is going to be giving you a black color to the Michaelis-Guttman body, or you can be using some other stains. But the point is important that chronic cystitis, E. coli infection, Proteus infection, and deposition of iron/calcium is going to be responsible for development of malakoplakia. Of course, not to be forgotten what I made a mention of, the von Henzemann cells, which are going to be the foamy macrophages, which are going to be seen in these patients. Another important example of a chronic cystitis that I would just make a mention of over here so that you do not goof up on a question over there is the interstitial cystitis, which is going to be associated with the presence of hemorrhagic spots that is going to be associated with chronic cystitis, and that is given the name of Hunner's ulcer. The only reason examiners may ask you a question about Hunner's ulcer is because of the fact that you got a very peculiar finding over here. There is going to be presence of mast cells which are going to be seen in this kind of an ulcer. So interstitial cystitis is a chronic cystitis in typical in females. Again, the presentation in the form of a dysuria, which is having the presence of mast cells, should be answered in the exams as Hunner's ulcer. So two important types of chronic cystitis condition that are commonly asked in the exams, and therefore we need to be familiar with them. Talking about the next important example of a topic, that is going to be something like the urinary bladder carcinoma. Now, as and when we are talking about the urinary bladder carcinoma, this is going to be characterized by the fact that there is going to be presence of an exophytic mass which is going to be causing involvement of the bladder, and the commonest clinical presentation of a patient is going to be the development of something like a painless hematuria. So classical history in the exam will be talking about an elderly individual who is having a presentation in the form of an episode or more than one episode of a painless hematuria. When we talk about urinary bladder cancer, we need to remind ourselves of the fact that majority of these cancers are going to be starting from an epithelial component. That means almost 95% of these cancers are epithelial in origin. Just about 5% are going to be mesenchymal or from the connective tissue. So far as the epithelial lining is concerned, we are intelligent enough to recall the fact that the commonest subtype over here happens to be the transitional cell carcinoma, because the urothelium or the transitional cell epithelium is the epithelium that you normally find in the urinary bladder. There is going to be the important risk factor in the form of tobacco exposure or in the form of smoking. Of course, people could be having the development of something like a squamous cell cancer, especially when there is going to be the presence of stones for a long duration of time. There is a variant of urinary bladder cancer which is going to be given the name of adenocarcinoma, which is typically seen in case of a situation when the individual is going to be having the presence of a persistent urachus. So keep that particular keywords in your mind: presence of stone, presence of urachus, presence of smoking or tobacco use, which is going to result in development of the important subtypes of the urinary bladder cancer. We also can have a link with our knowledge of microbiology over here, in which especially in the Middle East, Egyptian countries, if there is going to be an infection caused by the bladder fluke, which is going to be schistosoma hematobium, even that over a period of time can cause chronic irritation and can enhance the risk for development of the urinary bladder cancer. The question which is very commonly asked in the DHA or the Dubai Health Authorities exam as well. Now, looking at the histological picture over here, you have the presence of infiltration of the bladder by hyperchromatic appearing cells, and this is what can be appreciated over here as well. So we could have had a better image, but then you can just have an understanding of the fact that yes, the commonest variant that you could have over here is the presence of a translational cell carcinoma. Of course, one of the recent exam questions which was asked in the JIPMER exam was the fact that in case of urinary bladder cancer, you are going to be having a situation which is going to be given the name of polychronotropism. Polychronotropism. Polychronotropism simply means the fact that there could be a presence of a multifocality both with respect to the location and with respect to the time that you're going to be having with this kind of a tumor. And this is a term I would just recommend you, if you can just remember that one line, that polychronotropism is a term that you associate with urinary bladder cancer. So far as the management of this kind of a tumor is concerned, we just need to be familiar with the fact that when we are talking about something like the transitional cell carcinoma, it has been shown to be having a very good response to the intravesical BCG, but for the other variants, we need to perform surgery of the patients, and at times we have to administer the anti-cancer drugs as well. So that takes care of our discussion of the important images so far as the renal section is concerned.